Welcome everyone to today's webinar. I am Emma Beamer with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session, which will be moderated by Scott Becker, publisher of Becker's Healthcare. You can submit any questions you have throughout the webinar by typing them into the box labeled Enter a Question for Staff and clicking Send. It is now my pleasure to introduce today's presenters. Adam Klass, Chief Technology Officer, is responsible for the architecture and development of large-scale data-driven applications, including Vigilance's Enterprise Intelligence Resources, EIR platform, which incorporates services-oriented architecture and open application programming interface capability, API, to aggregate and interact with disparate data across any healthcare enterprise. Adam holds a BA in Political Science from the University of Kansas, as well as an MA in Public Administration from the University of Illinois in Chicago. Bart, Chief Data Scientist, leads the data science team in building customizable statistical and predictive models that are fully integrated into the Vigilance intelligence platform. He holds an MS in mathematics from Georgia State University and a PhD in health services research from the University of Minnesota, and has an extensive experience in optimization, discrete event simulation, and data modeling. Eric Rose serves as Clinical Informatics Manager and IS Liaison for Quality Initiatives at Orlando Health, a 1,700-bed health system providing a wide range of services, including Central Florida's only Level 1 trauma center. He earned his BS in Pharmacy and PharmD from the Massachusetts College of Pharmacy and Allied Health Sciences, and completed a postgraduate residency with Eggleston Children's Hospital at Emory University. It is now my pleasure to turn the floor over to Adam to begin today's presentation.
Hello everyone, and thanks for joining today. Next slide, please. So I wanted to start off and just give everyone a bit of a background around Vigilance. Our company was founded in 2001. We're a software as a service, so our hospitals and systems don't have to install any hardware or software in order to use the services that Vigilance provides. And for many years, we've really been focused in the area of real-time surveillance. Our corporate office is out of Minneapolis. Our IT group is primarily in Chicago, as well as our support, and many of our clinicians are out of our Chicago area. Currently, we have over 350 hospitals around the country that are using our real-time and predictive services. And you can see some of the names here on the right. We're running in very large health systems. We're running in very large hospitals at maybe 1,500 beds. We also have hospitals on the smaller side that are 100 beds. This is a very scalable and customizable platform that we've designed. Currently, we're at 100% client retention, and our longest running client has been running for 13 years now. Next slide, please. So what Vigilance really provides is a platform, and really what the intent of Vigilance is to really try to automate a lot of the manual data collection processes that the clinicians run into during their daily workflow within the hospitals. We're a layer that sits on top of the EMR, and really our goal is to derive all of the value out of all of that great data that's within the EMR and really affect patient care in real time. So if we were to start at the bottom of this diagram here, what Vigilance is doing is we're listening for outbound information from the EMR, primarily as HL7 outbound messaging that's coming into our platform. So this is a platform that's running 24/7, so we're continually listening for this data as it's coming through. And then what Vigilance has designed is a set of data normalization services to really take this data and make some sense of it and build some relationships together so we can start to ask interesting questions of the data in real time. So that's what our data normalization services provide. Literally any clinical element within the EMR can come into this platform and be used within these real-time rules engines. And then what Vigilance is designed is a process that runs every few minutes that really is set up to answer any sort of clinical scenario that a clinician needs to be tracking in real time within their system. So our rules engines have the ability to trigger off of an event also look for guidance when that event triggers, and also allow for a time period for that proper guidance to actually be implemented. And we're able to track all of that. We have very simple rules that you can run within our system, as well as very sophisticated rules, which would have multiple filtering opportunities within there. We have keyword searching within our documentation, and chest X-rays that can be tied into these rule sets. So we literally have hundreds of these events that can easily be chained into this engine to really follow any clinical scenario, and this ties really well into our real-time workflows that we provide to our clinicians. Several times a day, we're taking all of this information. Information is never purged out of the Vigilance databases. And we're rolling that up into an enterprise data warehouse for our clients. So our systems are able to look across their system and really do some really good benchmarking and productivity measuring across the system. So that's a big value to our clients. And the other area that Vigilance is involved with is interoperability service. So instead of looking at traditional methods such as HL7 and flat files to feed this platform, we're starting to bring in modern API technology to be able to make RESTful web service calls in order to feed this platform as well as taking all of the workflows and reporting that we offer through our secure web portal and actually getting that embedded back into the EMR as well. So there's a set of services that Vigilance provides. We have a very robust service around pharmacy and antimicrobial stewardship, as well as infection control. Vigilance also provides what we call discrete services. So with the power of this rules engine and the ability to be able to trigger off of any data elements that are coming into it, we're able to design custom rule sets for our end users to really focus on a really key problem area that they may be having, and then be able to operationalize that and get that into a real-time workflow along with reporting for them. So that's our discrete service. And then today we're going to be talking about our predictive analytics in a lot more detail. So we can go on to the next slide now. So these are some of the different types of real-time services that Vigilance provides in a little bit more detail. As I mentioned, this is a real-time service that we provide. We're listening for data 24/7. What's very unique about the Vigilance engines is we have the ability to have what are called exception-based rules. So if a particular scenario happens within the hospital, here's the exact guidance that we want to see happen within a period of time, which is really valuable as you have alerting systems that can cause noise to really have output of these rules engines that are truly actionable for the clinician. We have thousands of these rules available within our library, but we also have an open rule library between the majority of our clients, so our clients are really able to share across and see what some of the best practices are, whether it's a community hospital or a pediatric hospital, and how they're tackling certain scenarios. So it's a very shared experience for our end users. And then just some of the things that we cover under these different types of services. So I mentioned discrete services. So we have a discrete service, for example, around sepsis and glycemic control, proactively tracking core measures, looking at DVT and readmissions in real time. When it comes to antimicrobial stewardship, we're really able to automate what's going on with a particular hospital's antimicrobial stewardship program down to a rule set and a set of reports for them. So we're able to track things like drug-bug mismatch and de-escalation opportunities and duplications of therapies. Being able to do antibiotic usage and antibiotic resistance and report that to the National Health Safety Network automatically is built within the system. So a tremendous amount of value that we're providing there for antimicrobial stewardship. Then the infection control, really taking all of the pieces that an infection preventionist has to deal with on a daily day, and again getting that down to a more automated process. So whether it's tracking suspected isolation candidates or reportables within a hospital in real time, or doing HIA surveillance. That's all available within the real-time rules running for infection control. We have direct submission to the National Health Safety Network, so the users can be directly within Vigilance and electronically submit their numerator and denominator data over. So tremendous time and cost savings there for them. And then overall, things that an IP has to do around prevention, we have a wealth of tools within the IC toolbox for them, whether it's cluster tracking or cluster alerting or outbreak alerts that are built in. So, and then overall with pharmacy, since we're evaluating all of the medications that are coming into the system, you're able to identify and prevent adverse drug events in real time, really mirroring any drug to any lab test result. Since the rules engines are exception-based, what our hospitals are able to do is they're able to have their renal dosing protocols built into the rules, and they're only being alerted when they're not following their own guidance. So they're able to automate a lot of their anticoagulation, renal dosing protocols, antimicrobial dosing within this particular service. And then really a wealth of reporting that we provide, whether it's antibiograms or days of therapy or drug utilization or full intervention documentation that's integrated within our workflows. Next slide, please. So what we've added to the platform in the last few years here is really the predictive analytics piece of this, and really how we wanted to tackle this in the same way that we're running rules in real time, and these rules can be customized. They're very flexible. We wanted to have a machine learning model that would actually plug in to this real-time data acquisition and rule engine processing. So as we're getting the clinical data from the hospital, as we're running very sophisticated rule sets around pharmacy, infection control, antimicrobial stewardship, and then our discrete services as well, what we're able to do in real time is we're actually able to feed all of this information into a machine learning model that's been custom built for that particular hospital or system based off of their cohort. And we're able to bring back a score and actually operationalize that and get that into workflow so that people can be actually on the floor, whether they're on a device or a tablet or at a PC, as the patient is perhaps acquiring something like sepsis. And Bart's going to talk about that in a lot more detail as we go through here. So next slide, please. And with that, I'm going to pass this over to Bart.
Thank you, Adam. And thank everybody for joining us today. So with all that Adam has shared with us about the Vigilance platform, what we've done with this platform is to specifically engineer it to add context to all the clinical data that we collect in the hospital. So for example, data around time, location, user. And with that, we can then build or design statistical analysis that are context-based and adds real value to the clinical data. So for example, we can do turnaround times around labs, microbiology, and we can then look at it by location, by unit, by day of week, by time of day. As a matter of fact, we did such analysis for one of our clients, and they realized that the turnaround time from when they collect vital signs to when those values actually get into the EMR database was in the order of 3 to 4 hours, which has real implications to if you have clinical decision support based on those values, then those decisions are going to be delayed by that factor of time, 3 to 4 hours. So this is really, really critical. And on top of that, we can then begin to tie outcomes to these time-based data. And this is what we've termed temporalytics. That is really looking at the effect of a delay in response to an event on outcomes of interest, such as length of stay, patient morbidity, and other things. So that's one level of or type of analysis that we're able to do with this platform. So be the data that's coming from pharmacy, from patient's history, from clinical diagnosis, we can tie all this to time and begin to do some real nice analytics around it. Now, beyond that, as Adam said, we have built a full-featured predictive modeling platform that plugs right into our existing platform. And so we can then begin to apply real advanced algorithms to clinical scenarios. And this platform is a state-of-the-art platform that can consume any kind of model that is out there today, be it in neural networks, support vector machine, decision trees, deep learning, all those state-of-the-art models that are being used by all the tech companies out there. We can leverage those algorithms. And so with this, we are able to really calibrate models to suit your patient population, and that is really crucial. In fact, I saw a quote from one data scientist that said that the literature today suggests that there is an average way to deal with an average patient at an average hospital, but no hospital wants to be an average hospital. So although there are great algorithms, great criteria out there, typically because of the fact that they have to have external validity, they typically work on an average patient. However, each patient might have unique characteristics that make their cohort different. And if you're able to leverage those unique characteristics in an algorithm, you're going to get far better results. So from this, we're able to then implement real-time risk scoring for each individual patient in your hospital. And those risk scores are updated every few minutes as new data is added into the model. Next slide, please. So as we begin to talk about our implementation of a sepsis algorithm, here we have a graphic that depicts a timeline of a patient who presents with sepsis during their hospital encounter. Now, so typically, a sepsis diagnosis will be made at the greater of when an infection or a new onset organ dysfunction is found. So what we have developed is to specifically try and preempt that diagnosis at an earlier time, so we can give the clinicians the time to act and stem the onset of sepsis even before it happens. Next slide, please. Now here we look at what some of the current approaches with dealing with sepsis are. The graphic on the left I picked from the Surviving Sepsis Campaign latest paper that was published, I think, in February last year. This was from the third international consensus definitions of sepsis, what they call the Sepsis 3. And here they looked at various criteria in identifying sepsis cases. They looked at the search criteria, they looked at the SOFA, quick SOFA, and LODS. And in this diagram, we have what we call the area under the curve score, where typically we are looking for a score between 0.5 and 1, with 1 being a perfect model or a perfect criteria. What we see here is that most of them are just doing average, and the LODS, which is a logistic model, is about the best model here. What we in Vigilance have done is to expand on the routine inputs that are typically used in the search criteria and add to it other important factors that might be germane to a particular hospital. So we are looking at things like age, the clinical history of the patient, comorbidities, other labs, and the key is that we build models that when new data becomes available, they are included into the model. And so it's very dynamic and it updates itself over time. Another key feature of our model, and it goes back to the fact that we're able to collect timestamps around every piece of data that comes into our platform. We look at what we call the temporal effects. So how fast is, say, a vital sign changing? How fast is the patient condition changing from baseline? And this allows our model to be very, very accurate. Then we apply machine learning algorithms to these models, train them on your own historical data, test them, validate them, put them in a staging area, run the models against real-time data for actual patients that are coming without showing the output, and make sure we evaluate it together with your clinicians before we put those models into production. And then once they are put into production, patients are scored repeatedly as and when new data comes to the model. Next, please. So the typical model development process that we use here in Vigilance is that we have a very collaborative process between your expert and the Vigilance team. Of course, we've done a lot of great work with many of our clients, and based on the science and the literature out there, we've built great base models. And then what we do is that when we begin working with your team, we look at the important differences that are in your institution, things that might impinge on the foundational models, and we incorporate those into the models. We also make sure that we train the models against your own historical data. and so that the base models are then recalibrated, and so the parameters are fine-tuned to incorporate any differences that might be pertinent to your population. Then we validate these models in real time in the staging environment, as I said earlier. Then we score each patient in real time, and then the scores are updated as new data flows in near real time. As Adam said earlier, every few minutes we pull in new data from the EMR, and then we use it to update our models. Next, please. So before I hand it over to Eric to tell us about their experience at Orlando Health, this is a summary of what we did with our partnership with Orlando Health. The problem here was two-pronged. First, to detect patients who have come to the hospital already presenting with sepsis and alert clinicians to deal with it. So we have a rule set that is specifically built based on the client's own criteria for identifying treatable sepsis that is currently presenting. Above that, we built a model that looks at the patient's characteristics, vital signs, clinical values, and alert physicians before the patient actually clinically manifests with the condition. So this gives them some clairvoyance and allows them to be preemptive. So the model inputs include vital signs, microbiology, labs, comorbidities, clinical history as far back as 90 days, demographic data. Again, we incorporate a temporal effect, looking at the differences between the time series measurements or repeated values. And so when we run this through the model, we come up with a score on a scale of 1 to 100, with 100 representing patients who are actually clinically manifesting with sepsis. And then as your risk increases, your score increases if you have not presented with sepsis already. Then in collaboration with our client, we evaluate the data and choose a cutoff at which some form of action will be, or some form of intervention will be done for the patient. And we present all this on a work list which brings together various important risk factors, various important metrics that a clinician would like to see as they care for the patient. In terms of performance of our model is currently showing sensitivity and specificity of around 90% with a positive predictive value of 70%. And that positive predictive value means that 7 out of every 10 patients who show up on that list who are actually patients who need some action performed on them. Next, please. Here's where I turn it over to Eric Rose to talk about their experience at Orlando Health.
Thank you, Bart. Just real briefly, a little background on Orlando Health itself. We're a 6-campus health system in Central Florida, in and around the city of Orlando, with about 1,700 beds. We are the level 1 trauma center for our area, and we do have a large women's and children's population, and a number of community hospitals, as well as our central academic medical center. So we've been a partner with Vigilance and a client of Vigilance, gosh, for probably about 10 years, using their tools with our pharmacy and our antimicrobial stewardship programs. And it's really been a pleasure to partner with them on this new venture and this predictive analytics, and to see where we can take these things. If we can go on to the next slide. So we participated with Vigilance in the early validation of Bart's algorithm, and some iterative development of the user interface on the dashboard. One of the things we learned early on was that we needed to narrow down the time frame definitions around organ dysfunction, and that helped us very quickly tighten up the predictive power of the algorithm. We've gone through a second round of validation, and then moved on to a broader pilot with about a half a dozen of our clinical units in partnership with the bedside nurses. A couple of things that came out for us early on, and I'm sure these are probably issues in nearly every location, but the timeliness of our nursing documentation. Bart mentioned one of their clients, they revealed the 3 or 4 hour lag at times between collection of a vital sign and documentation in the EMR. I suspect that's optimistic for some of our units, and so we're working to improve that as well and to bring attention to that with our nursing leadership, because obviously we're sending data over to the Vigilance folks every 3 to 5 minutes in most cases, but if it's taking 3 hours for that data to reach the EMR, there's some artificial lag there that we've had to combat. And then the other thing we found is we really have a ways to go in some areas with the structure in our EMR content, but where we had structured data available that we could flag and send over to Vigilant, they've been incredibly responsive in incorporating those into the algorithm and returning back changes to us. Go on to the next slide, please, Emily. So the way we structured our pilot, we considered a few different models. We do have a rapid response team model at several of our campuses with centered around intensive care prepared nurses who respond sort of to a pre-code situation with the patients. And we did consider having those folks be the primary pilot for the predictive analytics dashboard, but due to some workload considerations and some other things, we decided to go with what we call our charge nurse model. What we did was we partnered several of our quality specialist nurses and a couple of the informatics team. We partnered closely with the charge nurses on the units that we're piloting, and around mid-morning when labs are back, when morning rounds are done, we would guide those charge nurses in reviewing the predictive analytics dashboard and identifying patients where they just need to take a closer look based on the risk score presented or the trending that's presenting. And this provided them with a way to triage the patients under their care and go partner up with the nurse at the bedside to do a closer assessment of the patients that were scoring at a higher risk threshold. Generally, the tool was very well received in our nursing units. I think we did see a very different level of enthusiasm from our medical surgical areas than we did from our step-down units. I think on the step-down units where maybe there was a smaller ratio of patients to nurses and maybe some more experienced nursing, the tool, we received feedback that it was helpful, but the most enthusiasm we got was from our med-surg area. And there is a comment there at the bottom of the slide. I won't read through, but that was indicative of a lot of the feedback we received informally and formally from the nursing staff involved, where gave them a chance to identify and intervene on patients that they otherwise would have had to wait for them to present with more clear clinical signs that they were in trouble. One of the things that we've struggled with early in the pilot was sort of orienting our nursing staff and our charge nurses to the predictive approach as opposed to a screening approach, where we've been very accustomed to a screening model where periodically during the shift the nurse will go in and run a screening algorithm based on the SIRS criteria to identify patients who are in the early stages of a septic response. Instead, we're now asking them to look at this predictive tool, and fortunately or unfortunately, living in Florida, we're very familiar with the National Weather Service and hurricane prediction, and so we've used that analogy quite a bit for our nurses. We say, we're not saying that there's a hurricane over you right now, but we're saying when you look at the weather map, you're inside that cone of prediction. So the intervention you want to make at that point can vary. You can apply a little more attention to that patient. You can adjust assignments maybe so that the nurse assigned to that patient is able to provide more attention, more hands-on approach. You can partner a more senior nurse with a more junior nurse. You could take some extra vitals. You may want to draw a lactate and some labs. Just gives you a chance to intervene before things sort of go south. Next slide, please. So this is a visual of the dashboard itself as we're using it today. You can see on the left-hand side you have the opportunity to filter down by location, and then also to set the predictive risk score that you want to filter your dashboard at. We've found we get the most utility if we look back between 12 and 24 hours, depending on the clinical unit, and we look for patients who have scored at a 70% or higher. Lower predictive scores below 70%, we did find we had the number of false positives grew to the point where we found it more beneficial to filter the 70% and above. And then going across the top, the first column on the right with the little conversation bubble was where we've collected our feedback from the nursing staff involved with the pilot. It allowed them to go in and insert comments. Hey, I agreed with this assessment. 1,300 today. We made an intervention. We drew an additional lactic acid, called the attending based on the dashboard, things like that. The next column over is actually more of a screening tool. The yes/no in that column depicts whether we're saying this patient actually is exhibiting signs of sepsis. So a yes in that column requires a more urgent response, or may indicate a patient that we've already identified and are already treating. As we come over, the risk value column is where we found the most utility, and that demonstrates both the current risk score, and then you can click on that little chart icon to see the most recent trend. And the same is true with all the quantitative values as you go across: blood pressure, temperature, respiratory rate. Now, these are not all the variables that are included in the Vigilance algorithm on the back end, but these were the variables we wanted to put on a dashboard to allow the bedside folks to immediately say, oh, wow, okay, that patient, so the third patient down on my list, they're at a 79%, but they're trending upwards. Let me just take a quick look across and see if there's somewhere obvious that I can focus my energy. Oh, I see we don't have any cultures drawn. The blood cultures are over 3 days old. Maybe it's time to draw a new set. And this allows a guided response. It's not a full view into our EMR, but it just allows some triage and some guidance of your initial response. You can go ahead to the next slide. And I think that's all my slides. I think before I hand it over, I think I'd also like to comment, we've expanded our pilot now to 6 units for a total of 8 weeks. We wrapped that up, and we've collected feedback from the nursing staff. And one of the things that has become apparent, as I mentioned earlier, is that we're really getting our best positive feedback from the medical surgical units. That seems to be where we're having the most impact at the bedside. Nearly 100% of the survey responses from those areas indicated that they nearly always agreed with the assessment on the dashboard, and were making changes in their plan of care based on it. Overall, we had about a 50% agree score, but that's when you remove out the intermediate care units and the sicker patients. We did get a lot more enthusiasm out of the med-surg folks. Our next step here at Orlando Health, we're meeting with our quality leadership next month to determine how best to roll out to a larger pilot where we can build up a sample size where we can really look at outcomes data and document that we're making a difference. And then in parallel, we're working with our pediatric hospital, with Arnold Palmer Medical Center, and we're going to begin validating and deploying a pediatric version of the predictive algorithm for those folks. And one of the key points there is we're going to start out with the acute peds population and then work our way up to the critical care areas. So I'm excited to see what we get back from that. With that, I will hand it back over to Adam, I think, right?
Well, I'll take this. So I wanted to highlight some of the things that make the Vigilance platform quite unique from traditional approaches to incorporating predictive analytics. As I said earlier, typically if you build models that incorporate several hundreds of hospitals from the northeast to the southwest, yes, those models will be great for an average patient, but it might miss some important characteristics of your particular cohort. So we pride ourselves in developing models very closely with our clients, and our model built very transparently. You know what goes in. We share the underlying risk factors and inputs with you, and make sure that you really have great confidence in the model, and that model is built purposely for you. Of course, as I said earlier, we learn from all the experiences we've had with other clients, and so we're not starting from scratch, but we make sure that we fine-tune the model, and that model works optimally for your cohort. Another important thing about the collaboration and partnership with Vigilant is that it's an ongoing collaboration. We don't put in one model and then that's the end. We continually evaluate the model as your institution uses the model. We have a production environment and a testing environment. the data that is driving the production environment can at the same time be passed to the test environment, where our data scientists continually monitor the models and look at the performance. As and when new feeds or new tests that were not previously available to you become available, and they have a potential to influence the outcomes of the model, we incorporate it, we build it, we test them, and if we find that we can get better accuracy with the new models, we can put them in production without any disruption whatsoever to the workflow. Those on the front ends would not see any changes in their workflow. What would happen then is that they are working with models with better accuracy. I think another important thing that sets Vigilance apart is that we've been working at this for quite some time now. We have a very large pool of clients, and the knowledge that we learn working with various clients, we are very eager to share it with new clients. And as we build new models, we bring those knowledge to bear. And it becomes very critical for conditions where you have very, very low incidences. For example, when you're dealing with pediatric sepsis and you begin to look at very small age groups, you don't often get the numbers you need to get the statistical power required to test in your models for one hospital. Here is where we can leverage various institutions together, partner with them, and then build models that would have enough statistical power. So I think Vigilance has a real competitive advantage in all these areas. Next, please. And the experience that we just shared with you around sepsis can be leveraged for many, many different areas, different conditions, readmissions. We are working on models that are looking at predicting hypoglycemic events. We're looking at C. diff, prediction. We're looking at readmission. So the possibilities are endless, and our doors are open, ready to work with you on any challenges that you are facing in your hospital. With that, I think that's the end of our slides here. Thank you, everyone, and we'll open it up for the questions.
Oh, fantastic. Just a fascinating area with such evolutions. So, Adam, Dr. Bart, Eric, thank you so much. I've got a whole host of questions from the audience that I'll start to work through. Let me do that, and one of the three of you can jump in and answer the questions. One of the questions is, someone wondering how the system assessments of patients with sepsis compare to the hospital definition of sepsis. For example, do your definitions in the system vary from hospital definitions? Can any of you take a crack at that question?
I can talk a little bit to that. When we first began validating the dashboard, we did find that the system was flagging sepsis over in the screening column, the yes/no column, more frequently than we felt was appropriate. When we sat down with Bart and his team and were able to refine that definition to better match what our clinical leaders felt like it needed to be in our setting. And as I mentioned in one of the early slides, it largely revolved around establishing time frames for some of the organ failure parameters. But our hospital had been using, at the bedside, the straight SIRS sepsis criteria for their screening tools, and the definition we're using with the Vigilance folks is taking into account quite a few variables in addition to that would really be difficult for a bedside clinician to sit down and check all those boxes and tick all those tick marks. But we can process that very rapidly and present them with that definition. But we were able to customize that locally and validate it with our clinical leadership.
Great. Thank you. So that it matches up closer with the actual hospital institution you're in and so forth. The next question that I'll ask you deals with how quickly the modeling is redone and retrained and sort of the confidence intervals in the performance metrics. We're so used to now on our phones and everything else, our word documents that our phones get so used to retraining so quickly what we've used before and so forth. How quickly do your models retrain and update?
Yeah, this is Bart. I'll take this. So the way our platform is, we can really dynamically retrain the models as and when new data comes in, as we score patients and they are discharged. And so it can dynamically retrain itself. But we don't do that, and there's good reasons why. These are really critical conditions we are talking about here. So we don't want to completely hand off the retraining and then the identification of cases to the model without any human intervention. So what we do is that we continually monitor the models ourselves. Every few months, we'll just go back to the drawing board and rerun the models based on the new data that we have captured, and then see if the new models that we've retrained are significantly better than the existing models. And beyond that, there is new knowledge coming out all the time. Scientific knowledge that is coming out. There is new understanding of the sepsis disease itself. There's new consensus definition around what is severe sepsis and all those things. So we deliberately take that decision not to hand off the retraining of the model to the machine without human intervention.
Gotcha. So more systematic to allow you guys to make sure it's hitting as you want it to hit.
Yes.
Gotcha. A follow-up question, can the clinicians access the vigilance tools through the EMR?
Yeah, so I can answer that, and then Eric, maybe you want to talk about what you're doing in Orlando Health. But yes, the way that we've designed our secure web portal, it's really just accessing a URL. We have what's called single sign-on. So once the users are logged into their network, there's a really a seamless way. And all of the EMRs have some really nice tools for being able to integrate third-party applications into the EMR. And Eric, I don't know if you wanted to follow on that.
Sure. Yeah, we're running a several versions out of date version of Allserve Sunrise locally here with us, and we're in the middle of an upgrade. We can present the Vigilance dashboard on a tab within our EMR. We can present the link out, the single sign-on link out as well. What I'm working on right now is trying to take an individual user's list of selected patients and pass that context over to Vigilance. And the obstacles to that so far have been internal on my side, but that would be my ideal, because then we could expand out to some of our physicians that maybe are not geographically locked down to a specific location. I could say, okay, well, here's your patient list for the day, and now let me show you their dashboard. So we're actively working on that.
And Eric, let me ask you a follow-up question. Support. Does the IT department have to support the Vigilance product, or how much support do you need internally for it, or how easy to implement?
Yeah, truthfully, not a lot. We're using our integration team and our reports team really just to set up the outbound feeds to Vigilance. And then as far as designing the rules and pushing information back and doing all that, that's been happening on the vendor side. So the hours that we've put into this pilot have really been boots on the ground, validating it in the clinical environment. There have not been a lot of IT hours involved.
And how about buying a separate hardware and software system internally? Is there a lot of that, or it's really done more on cloud and through Vigilance?
If I understand the question, really, we're just going through the cloud to Vigilance. It's a complement to the native decision support features in our EMR, but not a lot of overlap, really. They have the ability to refine down the rules and set up the dashboard a lot more cleanly than I can with custom development internally.
Got it. I've got a handful more questions here. Let me move towards a couple of those. Use of this, and Adam and Dr. Bant, this might be a question for you folks. Sepsis notoriously difficult to diagnose consistently, even among critical care experts. How do you define sepsis when calibrating the model?
Thank you. So, and this is really one of the reasons why going with off-the-shelf models become very problematic, and again, why we work very closely with a client to develop some of these definitions, because whereas there are consensus definitions, when you go from client to client or hospital to hospital, as we've observed, there are small changes on the margins or tweaks at the margins as to how these criteria are implemented. When it comes to, for example, looking for a threshold around temperature, you might see one institution looking at 101 degrees, another one will be looking at maybe 100.4 degrees Fahrenheit. And so, to the question specifically, these things, where we go to the literature as a base, but we really talk to the hospital and ask them, how do you today identify a treatable sepsis? Because that is where, at the point where the doctor would decide to act. If I predict it based on some theoretical definition, and the doctor sees it and says, well, really we don't act in these situations because of the protocols we have here, then we are going to make predictions that are not really actionable. So yes, there is the science, and we look at the science very critically, but we make sure that we have the buy-in and we have the knowledge from those who are on the front lines.
And so a couple follow-up questions. Is there a way to modify the tool or monitor treatment as it pertains to CMS sepsis measures?
I know perhaps Adam would speak to that, but as a matter of fact, in consonance with our predictive model, we have discrete services around this, which specifically looks at the CMS definitions, monitors them, collects the data that is required, make sure that those CMS requirements are followed. Things like the time to the first culture, time to the first antibiotic. So yes, we have the ability to really incorporate those CMS definitions. I don't know if Adam, you have something to say to that.
Yeah, I mean that's really the value of having the type of rule engine that Vigilance provides, is you are able to take those criteria and get those into rule sets, so you can be tracking those in real time. You can also be incorporating these scores that we're building on the patient in real time as well, and bring that into the workflow. So you can really get the real time piece as far as from CMS, and you can also get the predictive piece all in one place.
There's a couple questions that follow up to that, really a different question, which is the Vigilance program usable in the emergency department or just on the hospital inpatient wards, or where throughout the hospital can it be used?
And this part, I'll take this again. So again here, really on the surface, to the end user, it might present as if there is just one model, but underneath, we are actually looking at a battery of models. And so, I mean, the typical timeline of someone who comes to the hospital is that in the first few hours, perhaps, there are just a handful of real valuable inputs that might drive the model in the emergency department. Over time, there will be labs coming in, there will be microbiology coming in, they might be put in a ward or the ICU. And so, as new inputs come in, as the patient condition changes, we incorporate all these additional data that is coming in. So it's very dynamic, and so it adapts to where the patient is, to how much risk factors are available. And so in a nutshell, we have models that are applicable to both the emergency department, in the floor, in the units, or in the ICU. And we work to make sure that we test these models for these somehow, different cohorts of patients, and make sure it works for all of them.
Great. There are a couple questions, and this is Emma question. Will the PowerPoint be available to provide to our attendees, in Emma or Eric? Will we be able to get that out to the attendees?
Yeah, I'm happy to hop in for that. So we have received a lot of questions about the materials, and you can expect more information to come via email following the webinar. So definitely expect some of the recording, some other materials coming to you soon.
Great, thank you. We've answered most of the questions here. I'm just working through to see which I'm missing so far. There's a question, and we've answered it in part, and I'm not sure, Bart, I think this is probably a question for you or for Adam, is how do you incorporate time series into the model? Is it based on extracting some descriptive stats from the time series, or pattern mining, or time series analysis? And what's the resolution for that?
Well, so that's a great question. I mean, theoretically, there are specialized algorithms that you probably can leverage to incorporate the time series data that we are collecting. However, I mean, with the medical data, time series is not presented as in a near nice fashion as you could get in other domains. But there are ways to engineer those time series features. You could look at the difference between consecutive values and engineer features out of them. You could look at rate of change because we do have timestamps. So there are very innovative ways that we do incorporate those time series features.
Got it. Eric Rose, I don't have a formal question, but just a couple thoughts on your experience so far with this.
Oh, that was the question. Okay.
Yes. Sorry about that. I'm sorry.
No, that's okay. It's really been a positive experience. It's exciting to kind of see where this is going and how it's growing. As I mentioned, I really think that this is going to find its biggest application for us with the general population, the acute care pediatrics and the adult med surg populations. In my own words, what it does is it sort of takes the experience and sort of that clinical intuition that comes with a more experienced nurse or more experienced bedside clinician, and it puts that in the hands of maybe a less experienced clinician or someone who's, like I said, has a heavy patient load, and it gives them a chance, it gives them sort of an extra set of eyes that says, hey, bed 6 over here needs a little more attention, whether that means you're going in there and just doing a hands-on assessment once an hour, or whether you're going to call for some help or contact a physician. It adds, to me, it adds the benefit of a depth of clinical experience that some of those individuals might not have acquired yet.
Gotcha. And there was a follow-up question that'll be, one of these will be on an Adam question. Adam, one of the questions is, the EMR companies try and broadcast that their systems can do this, or they'll have modules for this and so forth. How do you answer that in terms of the ability for those to provide predictive analytics versus what you guys do? Maybe you'll answer that, and maybe also, Eric, you could discuss why you went with this versus just trying to tack onto your own EMR and use that.
Oh,
yes, I can. Go ahead, Eric. Yeah, go ahead, start, Eric.
That part's easy. We do quite a bit of customization within our EMR, and I'm sort of neck deep in most of that, so I'm pretty aware of what's within our capabilities and what isn't. And development on this order and the sophistication of this sort of algorithm for the predictive analytics is just beyond what we could do internally.
Gotcha. So, in Adam, do you want to jump in on that question as well?
Yeah, just for a moment. I mean, really what Vigilance is offering is a service that's fully supported and maintained by IT and full-time clinical resources here at Vigilance. And we do have a very robust rules engine that allows for a lot of flexibility and customization, and really goes to what Eric is talking about. So I don't really see ourselves as competing against something that the EMR may be doing. I really see ourselves as a service that can be plugged in very quickly and complement what they're already doing within the hospital.
Great. There's a great question on how is this being used to improve department performance, responsiveness. how does the program work to help people identify, treat shock, and will the model identify places for improvement to avert increasing risk? And are there ways to use to help determine problems with the hospital's staffing or departmental response to sepsis and so forth? There's a number of questions sort of boiled into that. Bart or Adam, I'm not sure that you could work off of that.
I can take a shot if you want.
Thank you.
I mean, to me, this is not an outcomes monitor. This is a clinical tool. So for us at Orlando, we're going to continue doing what we've always done with sepsis and looking at our outcomes, looking at our compliance with the best practices and now with the core measure requirements, and we can use that to isolate places where maybe we're getting that second lactate too many hours out, or we're intervening with fluids too many hours out. And actually some of the other Vigilance tools outside of the analytics dashboard will aid us with that. But one of the things I'd like to see as an outcome of this actually would be our incidence of sepsis diagnoses may drop as we begin to intervene before the patients really have met the clinical criteria for that ICD-10 code. I'm prepared maybe though to see that the patients that proceed to become severely septic or to proceed to shock despite these interventions are probably going to be the sicker of our sickest. And so while I'm hopeful that our incidence of sepsis declines, I'm prepared that we may see an increase in mortality among the smaller population that does reach shock. But that's really all conjecture at this point.
And let me ask Eric a question, because he's probably the most hands-on experience with this in his own hospital. And the intended users and consumers for the predictive model and ease of use. And Eric, I've got a couple questions baked together, and I know that Adam and Bart will have their own thoughts on this, but would like to get your thoughts from actually using this in the hospital currently. There's really two questions that come together: the intended users and consumers for the predictive model and the ease of use, and then separate, many hospitals have currently multidisciplinary teams for sepsis. Is this complementary to their efforts and what they're doing?
Sure. So the intended users, for us locally, the intended users are really the clinicians at the bedside, both the nurses and the physicians. I think right now for ease of use, it's a little easier for my nurses to get to it. And like I said, that's primarily because I can better filter down by location, and the nurses are confined to a specific location. But we're working with our hospitalists as well to integrate it into their workflow. As far as the multidisciplinary team, the model, we call ours our rapid response team, and they have a number of responsibilities, but they're available to be called by the nursing staff or really by any clinical staff who think a patient may be heading south but not quite reaching the point where a code needs to be called. And they'll respond, lay an extra set of expert eyes on the patient, and help determine what the next step should be. So I definitely see this as a proactive tool that a group like that can use, and to identify patients maybe, like I said, that they have not been called on but maybe should be called on. And so if they could generate a list for the whole house and say, gosh, here's 3 patients that we don't have on our watch list, and we're going to go take a walk down and just lay eyes on them. I think that there's a lot of value in a tool like this in that kind of setting.
And let me do one last question with Adam, which is how do people follow up with your company if they're interested in learning more about this?
Yeah, as far as following up, you can go to our public website, so www.vigilancecorp.com. Would probably be the best way to get in touch with us. There's a contact link on there, and someone will get back to you very quickly.
Great. Eric Johnson, I know that you're on the phone in the background. Could you also give us your contact information too, in case somebody wants to get to Vigilance directly?
Yeah, absolutely. Hello, everyone. You can reach me at ejohnson@vigilancecorp.com.
Great. And if Eric, I don't mean to, I won't share your information with everybody, but if people wanted to talk to Eric further about this, Bart about this further, or Adam about it further, I'm sure they'd love to, quite frankly.
Oh, absolutely.
Eric's So that would be great. And then Eric Johnson could get you in touch with any of them to talk further about this, whether you're looking at buying a Vigilance project or not, but to further understand the developments in this area, because it's so quick how this predictive analytics and the use of these types of tools are being used and put to real work in just literally the last year or two, after so much talk about it for a decade. So just a fascinating development. Adam or Bart or Eric, I don't know if any of you had any closing words or thoughts you wanted to share with the audience, or just encouragement for their journey through this type of thing.
Well, I mean, this is Bart, and what I would say is that, Scott, as you just said, there is a lot of development in this area currently, and I think we are realizing that the traditional approaches are not really going to give us the optimal results, and that each hospital is unique, and we don't want to be average hospitals. We want to be top hospitals. So we would have to begin to deploy some of these predictive algorithms, which are specifically designed with your patient cohort in mind. And this is exactly what Vigilance does, and we're very happy to work with anybody out there who is willing to innovate.
Well, I appreciate your comments so much. It's been fascinating for me to watch for the last several years Vigilance grow and the level of sophistication that they've brought to the table, combined with the ease of trying to make it easy for people to use, which is part of the reason why Eric's on the phone. So I appreciate you guys joining us so much today, and our audience as well. It's just so informative and interesting to see all these new things that are going on. So thank you to everybody. Eric can get you the slides as well, but Emma and our team will make sure everybody gets them within the next week, as long as that's okay with Adam and Bart and Eric and Eric. We'll get those out to everybody quickly. And if you don't get them quickly and want them, please do follow up with our team, and we'll make sure we get them to you right away. Thank you, everybody. Emma, I'm gonna close up because I know we're already past the hour, and I know we're going to start losing people quickly. But thank you, everybody, for joining us today. Thank you, guys.
Thank you very much.
Thank you.
Thank you.
All right. Bye-bye.